Hello and welcome to Insight Ophthalmology. I am Dr. Amrit and today we are studying the anatomy and the important clinical points related to the oculomotor nerve, which is the third cranial nerve. Let me give you an overview before we go into the details. The oculomotor nerve arises from the midbrain. From there, it passes into the interpeduncular fossa. This part is called the subarachnoid course or the cisternal course of the third nerve. Then it enters the cavernous sinus, which is the intracavernous course, and after that it goes into the orbit, forming the intraorbital course, and finally it supplies the eyeball, specifically the extraocular muscles. So we will be discussing all of these in this video. Let's first talk about the functional components. The oculomotor nerve has two main functions. Let me show you these components one by one. In this picture, you can see the somatic motor component or the general somatic efferent. These fibers are supplying the superior rectus, medial rectus, inferior oblique and the inferior rectus. The lateral rectus and the superior oblique are supplied by other nerves like the sixth nerve and the fourth nerve respectively. The general somatic efferent fibers supply these muscles, and when they are damaged, the eyeball moves outwards and downwards. This happens because the lateral rectus is still functioning, which is supplied by the sixth nerve, and the superior oblique is functioning because it is supplied by the fourth nerve, which is going to depress the eyeball. So, the eye is going to take a downward and outward position, while the remaining muscles are affected. We'll discuss this more in detail. Now, this diagram will make the functions of and the movements of each muscle clearer. If you're not familiar with the eye movements yet, you can visit our video on the anatomy of eye movements. Now let's discuss the parasympathetic component or the general visceral efferent. The general visceral efferent fibers supply the ciliary muscle of the ciliary body and the sphincter pupillae muscle of the pupil. The sphincter pupillae is located in the iris near the pupil, and it causes the constriction of the pupil. The parasympathetic nerve supply is always responsible for pupillary constriction, and the sympathetic supply is responsible for dilatation of the pupil. You can visit our video on the anatomy of the iris for more details. The ciliary muscle is also an important muscle for accommodation. When the ciliary muscle contracts, the zonules will relax and the lens becomes more rounded. This is known as accommodation. So, the third nerve also plays an important role in the accommodation through the general visceral efferent fibers. Here you can see the summary of the somatic motor and the general visceral efferent fibers. Now let's talk about the anatomy of the third nerve in detail, how it originates and where it courses. The third nerve nucleus is situated in the midbrain at the level of the superior colliculus, as you can see in this diagram. This is a cross section of the midbrain. On the top of the page is the dorsal portion and at the bottom is the ventral portion. It has been labeled as well. In the center, you can see the small opening of the cerebral aqueduct. Surrounding it is the periaqueductal gray matter. The nucleus of the third nerve or the third nerve nuclear complex lies in the ventromedial aspect of the periaqueductal gray matter. It forms a column of about 10 millimeters long, which extends superiorly up to the floor of the third ventricle and below up to the level of the trochlear nerve nucleus. The trochlear nucleus is situated at the level of the inferior colliculus. In this picture, the label quadrigeminal plate refers to the superior and the inferior colliculi together. The third nerve nucleus is at the level of the superior colliculus, the fourth nerve nucleus is at the level of the inferior colliculus, and the extent of the oculomotor nuclear complex is marked in red in this diagram. After knowing the location, let's look at the nuclear anatomy. The oculomotor nuclear complex has two main parts. The main motor nucleus, which gives rise to the somatic motor efferent fibers as we discussed, and the accessory parasympathetic nucleus, the Edinger-Westphal nucleus, which gives rise to the general visceral efferents. This is a zoomed image of the nucleus. The Edinger-Westphal nucleus, which supplies the parasympathetic fibers, it sits at the rostral end of the nuclear complex. Let me explain the entire nuclear arrangement with this schematic diagram. At the rostral end in blue, you can see the Edinger-Westphal nucleus. Below that, you see paired nuclei, and at the bottom there is one unpaired nucleus called the central caudal nucleus. This central nucleus supplies both the levator palpebrae superioris muscles, which elevate the eyelids. In between these, you can see 4 paired nuclei. The outer ones are the lateral subnuclei, and the ones closer to the center are the medial or the paramedial subnucleus. The lateral subnuclei can again be divided into dorsal, intermediate, and ventral groups based on their position. The dorsal nucleus supplies the ipsilateral inferior rectus. The intermediate lateral nucleus supplies the ipsilateral inferior oblique, and the ventral lateral nucleus or the ventrolateral nucleus supplies the ipsilateral medial rectus. Now, the median or the paramedian nucleus supplies the contralateral superior rectus. So, there's a crossover only for the superior rectus fibers, and this occurs at the level of the medial subnucleus and not the lateral ones. So, this schematic shows the crossing clearly. The medial subnuclei sends fibers to the contralateral or the opposite superior rectus. The central caudal nucleus supplies both the levator muscles, and the lateral subnuclei, we already know, they supply the ipsilateral IR, IO, and the MR. Now let's briefly talk about the Edingo-Westphal nucleus, the accessory parasympathetic nucleus at the rostral end of the complex. It gives rise to the preganglionic parasympathetic fibers that are going to join the third nerve, and these fibers are going to pass along the inferior division of the third nerve, traveling with the branch to the inferior oblique. We will discuss this again when we cover the divisions of the third nerve. The Edingo-Westphal nucleus controls the light reflex and the accommodation reflex. It is believed that the cranial half controls the light reflex and the caudal half controls the accommodation. There is also a debated nucleus of Purlia that may contribute or that may help with convergence, and it is often considered to be a part of this complex. This picture shows how the rostral part of the nucleus sends fibers to the pupil. These fibers first synapse in the ciliary ganglion, the parasympathetic ganglion of the third nerve, and from there the postganglionic fibers go on to supply the ciliary muscle and the sphincter pupillae. Now let's briefly look at the light reflex pathway and how Edingo-Westphal nucleus is involved. The light enters the retina. From there, the signal travels along the optic nerve to the pretectal nucleus. Does not go to the lateral geniculate body for the light reflex pathway, and at the level of the pretectal nucleus, the fibers are going to cross and project to both the Edingo-Westphal nuclei. From the Edingo-Westphal nuclei, the efferent fibers begin and travel to the ciliary ganglion, and from there, the sphincter pupillae causes pupillary constriction. This bilateral projection explains why shining light in one eye constricts both the pupil. That is the consensual light reflex. So I've explained this in detail in the video on pupillary light reflex. Now, this oculomotor nuclear complex has many connections. It connects with visual cortex, with frontal eye fields, the abducens nerve, trochlear nerve through the medial longitudinal fasciculus for the horizontal graze. It also connects with the centers for vertical and torsional movements. So you don't need to memorize all of these. Just remember that a lesion at the nuclear level rarely affects only the third nerve. It usually produces additional deficits like vertical gaze palsy or torsional abnormalities because of these extensive connection that the nucleus has got. Another important point here, a unilateral nuclear lesion will cause bilateral ptosis. And why is it so? Because the central caudal nucleus supplies both levators. You are also going to see a superior rectus weakness, but on the contralateral side, because these fibers cross from the medial nucleus. So remember this very high yield point regarding the nuclear affliction of the third nerve. The pupillary findings, however, may vary in nuclear complex disorders because the Edingo-Westphal nucleus may or may not be involved. Also, the nuclear lesions almost always produce a complex gaze deficit because of their involvement with the vertical gaze centers. These lesions are rare, and the common causes will include some vascular events or demyelinating disorders. Now let's discuss the fascicular part of the third nerve. After the third nerve emerges from the nucleus, it passes close to the red nucleus, the substantia nigra, and the crus cerebri. This segment of the nerve where it travels within the midbrain is called the fascicular part. The right and the left halves of the midbrain are the cerebral peduncles, and the space between them is the interpeduncular fossa. Lesions involving the fascicles of the third nerve usually affect not just the nerve itself but also the surrounding structures, giving rise to a variety of midbrain syndromes. Let's go through them. In Weber syndrome, the lesion involves the third nerve fascicles as well as the part of the crus cerebri. The crus cerebri contains descending motor fibers to the contralateral side of the body. Therefore, patient here will present with ipsilateral third nerve palsy and contralateral hemiplegia. Next, we have the Benedikt syndrome. In Benedikt syndrome, the lesion, which is shown here in green in the diagram, it affects the third nerve fascicles and the red nucleus. Damage to the red nucleus leads to contralateral extrapyramidal symptoms such as the intentional tremors. So the findings of the Benedikt syndrome include ipsilateral third nerve palsy and contralateral involuntary movements or tremors. Before discussing the next two syndromes, let's review the decussations of the superior cerebellar peduncle. The cerebellum connects to the brainstem through three peduncles. The superior cerebellar peduncle decussates at the level of the inferior colliculus and then ascends to the red nucleus, to the thalamus, and finally to the cortex. The location of the lesion relative to this decussation determines whether the ataxia is going to be ipsilateral or contralateral. So if the lesion occurs before the decussation or caudal to the decussation, it results in an ipsilateral cerebellar ataxia. However, if the lesion occurs after the decussation, it causes a contralateral cerebellar ataxia. This helps explain the variations which are described in different textbooks. Let's discuss the Nothnagel syndrome. In Nothnagel syndrome, the superior cerebellar peduncle is involved along with the third nerve fascicle. So, the findings include the ipsilateral third nerve palsy and cerebellar ataxia. The ataxia could be ipsilateral or contralateral depending on whether the lesion is before or after the peduncular decussation. This is why different sources may list different sites of ataxia. The Claude syndrome is essentially a combination of the Benedikt and the Nothnagel features. The lesion here affects the red nucleus, the superior cerebellar peduncle, and the third nerve. So the clinical findings will include ipsilateral third nerve palsy, contralateral tremors, and ataxia. The ataxia here is usually contralateral because most lesions here will occur after the decussation of the superior cerebellar peduncle. And this is the reason why most textbooks will describe contralateral ataxia in Claude syndrome. Now let's talk about the basilar or the cisternal course of the third nerve. After the nerve comes out through the interpeduncular fossa, it enters the basal cistern, and this is known as the basilar or the cisternal course of the third nerve. Here it has some very important relationships. As you can see, it emerges between the posterior cerebral artery and the superior cerebellar artery. And as it comes out between these two vessels, it also travels parallel to the posterior communicating artery and then continues forward until it reaches the cavernous sinus for its intra-cavernous course. This is a very important point. The basilar segment of the cranial nerve 3 runs alone in the subarachnoid space, and therefore isolated third nerve palsies are often basilar in nature. Another important point here is the arrangement of the fibers. In this diagram, you can see the somatomotor fibers are arranged centrally, and the pupilomotor fibers, which are the parasympathetic fibers, they lie superficially at the periphery of the nerve. The blood supply also matters. Each nerve has a vasa nervosum, which supplies the inner part of the nerve, so it mainly supplies the somatomotor fibers. The superficial pupillary fibers are, however, supplied by the branches of the pia mater. So when something compresses the nerve from the outside, it usually affects the superficial pupillary fibers first, leading to a dilated pupil. A classic example here is the posterior communicating artery aneurysm. This aneurysm presses on the third nerve and produces an isolated third nerve palsy with pupillary involvement, because the pupillary fibers here lie on the surface in this segment. So initially it's the pupillary fibers which get involved, and later on, if the compression is advanced, or if it advances, it reaches the somatomotor fibers as well, and then it will cause complete third nerve palsy. A similar mechanism also occurs in raised intracranial pressure, such as from an extradural hematoma. As the pressure increases in the supratentorial compartment, it pushes the medial part of the temporal lobe, that is the uncus, downwards and medially. This is known as the uncal herniation, occurring secondary to the raised ICT because of extradural hematoma. This uncus or the uncus can compress the third nerve at the tentorial edge, causing the early fixed dilated pupil that is seen in case of uncal herniation. Initially, the herniation causes just the pupillary dilatation alone. Later, as the compression worsens, the central somatic fibers will also get affected and the palsy becomes complete. Uncal herniation has other features as well. Along with the ipsilateral third nerve palsy, the brainstem may get pushed against the opposite tentorial edge, and the contralateral third nerve can also be affected, and this is known as a false localizing sign, because here the main lesion is present on the ipsilateral side, but the features are coming on the contralateral side. The posterior cerebral artery can also get compressed, and this artery supplies the visual cortex, and therefore compression of the posterior cerebral artery can lead to contralateral homonymous hemianopia. So in these lesions, the pupil gets involved along with the somatomotor component, and therefore this is known as pupil afflicting third nerve palsy. When only the pupil is involved, it's called as the internal ophthalmoplegia. When the extraocular muscles are only involved, it's known as external ophthalmoplegia. And when all the muscles and the pupil is involved, then that is known as complete ophthalmoplegia or complete third nerve palsy. And when only some of the muscles, one division of the third nerve gets affected, then that is known as the partial third nerve palsy. Alright, so pupil involvement is a key feature of these lesions which are compressing the superficial fibers. On the other hand, an isolated third nerve palsy with pupil-sparing is commonly seen in microangiopathies like the diabetes mellitus. In these cases, the smaller vessels are affected first, and these vessels are the ones which are supplying the central somatomotor fibers, so they get damaged here in diabetes. The superficial pupillary fibers will remain intact, leading to the pupil sparing. By now, the idea should be clear. Pupillary fibers involvement, usually it is the compression from outside. Pupil sparing third nerve palsy, it's usually the microvascular ischemia. However, these pupil rules are helpful but not absolute. There are exceptions. For example, the microvascular palsy can sometimes have a mild pupillary involvement. About 1 in 6 microvascular third nerve palsies show a mild degree of anisocoria or sluggish reaction of the pupil, and this happens because the ischemia can progress from the center outwards and involve the superficial fibers, though this is uncommon. On the other hand, compressive lesions may not always show an early pupillary involvement. About 36% of compressive lesions may initially spare the pupil, and this is seen in early posterior communicating artery aneurysms or if the tumor is slow growing. Similarly, trauma and post-surgical lesions can also produce third nerve palsy, and they often involve the pupil because of stretching of the nerve or traction on the superficial pupillary fibers at the tentorial edge. So in trauma, assume a compressive mechanism until proven otherwise. Now let's talk about the intracavernous course of the third nerve. After leaving the cistern, the oculomotor nerve enters the cavernous sinus. In this skull cross section, you can see the posterior clinoid process and the anterior clinoid process. The third nerve enters the cavernous sinus by piercing the roof just lateral to the posterior clinoid process. That's an important anatomical landmark. From the roof, the nerve descends and travels in the lateral wall of the cavernous sinus. In this coronal view of the cavernous sinus, you can note the order of structures within the lateral wall. The oculomotor nerve most superior, trochlear nerve, the ophthalmic division of the trigeminal V1, maxillary division of the trigeminal V2. The mandibular division V3 travels outside the cavernous sinus. Within the sinus cavity itself lies the internal carotid artery and the abducens nerve, which is the sixth nerve, which is positioned more medially and inferiorly. As the third nerve travels through the cavernous sinus and reaches its anterior portion, it divides into two branches, a superior division and an inferior division. If one of the division gets affected, it is known as the partial third nerve palsy. The same can be seen in the sagittal view, where the oculomotor nerve marked in green color emerges from the midbrain, moves forward, and then bifurcates into the two divisions in the anterior cavernous sinus. An important clinical point regarding the intracavernous segment of the third nerve is that the third nerve is situated very close to the fourth nerve, sixth nerve, V1, V2, and also the sympathetics around the internal carotid artery within the cavernous sinus. And therefore, isolated third nerve palsy is uncommon in the intracavernous portion. Instead, patients with intracavernous segment third nerve palsy would show you multiple cranial neuropathies involving the third nerve, fourth nerve, sixth nerve, and also there will be sensory loss along the V1 and V2 division of the trigeminal nerve. Now, what about the pupillary involvement in the cavernous sinus? In the intracavernous third nerve palsy, the pupil is usually spared. In fact, the pupil may even appear constricted if the sympathetic fibers which are running in the cavernous sinus around the internal carotid artery are affected, creating a mild Horner-like picture. So this helps you differentiate the cavernous sinus disease from a cisternal compression. In a cavernous sinus disease, you will have constriction of the pupil because of the sympathetic fibers that might get affected, or the pupil might be normal. Whereas in the cisternal compression, or the compression because of aneurysm in the subarachnoid space, the pupil is typically dilated. What are the causes of intracavernous third nerve palsy? The lesions here might include systemic conditions like diabetes causing microischemic cranial neuropathies, pituitary apoplexy which can extend laterally, then aneurysm and meningiomas of the internal carotid artery, carotid-cavernous fistulas, Tolosa-Hunt syndrome, cavernous sinus thrombosis. All these things can affect the third nerve within the cavernous sinus. Because of the tight anatomical space, these typically are going to present with multiple cranial nerve deficits and not just the third nerve involvement. From the cavernous sinus, the oculomotor nerve enters the orbit through the superior orbital fissure. Here, it is divided by the annulus of Zinn into three compartments. The middle compartment carries the superior and inferior divisions of the third nerve and the nasociliary branch of the V1 division of the fifth nerve. Also, the abducens nerve, that is the sixth cranial nerve, enters through the middle compartment of the superior orbital fissure. Then it basically has those two divisions that I talked about. So the superior division of the third nerve is the smaller division, and it travels upwards and lateral to the optic nerve and basically supplies the superior rectus and the levator palpebrae superioris. Therefore, a superior division palsy will cause ptosis and weakness of elevation. What about the inferior division of the third nerve? The inferior division is the larger one, and it gives rise to three branches, one to the medial rectus, one to the inferior rectus, and the longest branch that goes to the inferior oblique. Importantly, the branch to the inferior oblique also carries the parasympathetic fibers to the ciliary ganglion, and that's why the inferior division lesions can also produce anisocoria or a dilated pupil. When there is lesion in the intraorbital segment, it's basically because of the orbital tumors, inflammatory pseudotumor, trauma, or vascular lesions, and because of the branching pattern, you get division specific deficits. In superior division palsy, you will get ptosis and loss of elevation. In inferior division palsy, we get loss of adduction, depression because of affliction of the MR and the IR, and loss of elevation in adduction because of the problem with IO, and pupil may be dilated. Also, complete third nerve palsy can result sometimes because of affliction of both the divisions at once, and that will lead to ptosis, down and outward movement of the eye, and a fixed dilated pupil. Now, here's a self-assessment question for you. If a patient has bilateral partial ptosis and a contralateral weakness of the elevation, the superior rectus, where is the lesion? If you know the answer, I hope all of you know the answer. Kindly give the answer in the comment section. So that was regarding the third nerve clinical anatomy and partially about the third nerve palsy. I hope you enjoyed it. Don't forget to subscribe to our channel Inside Ophthalmology for future videos. Thank you for watching and have a nice day.